All right, thank you, Amy. There's one last thing I wanted to call out about music in that it's interesting too how when you listen to songs that are familiar to you, you can actually quiz yourself on the lyrics, and then it takes your mind away from whatever it is you're experiencing at the hospital. And I know that there's this term that psychologists use that's called highway hypnosis. And highway hypnosis is something that maybe some of you have experienced where perhaps you're driving home from work and you get home and you're like, yeah, I have no idea how I just got here. Because your mind, even though you drove there safely and got there okay, your mind was just elsewhere because it's almost this entranced kind of a thought process. Well, the same thing can happen with music. And I bring this up because, as I alluded to with my radiation treatments and having my songs that I was familiar with playing at the same time, one day in particular, there was a song that was playing, and rather than thinking about the fact that I had radiation coming in my head and hitting whatever was in its way besides the tumor, I laid there and I thought about the song that I was listening to, and I quizzed myself on the lyrics. Well, before you know it, the radiation session was all of a sudden done, and the machine turned off. And for a split second, I kid you not, I was disappointed that the radiation stopped. Okay, I shouldn't want more radiation in my head, but I wanted to finish the song. It's like I forgot where I was. And so that's why people will call it, or the equivalent of like a highway hypnosis, where, logically you might know one thing, but just kind of your mind is just elsewhere, and it can be your friend. So now, Amy, I know we have the reception that's coming up. Are we doing the Q&A session before that still? If anybody has any questions for any of the speakers that we had today, we want to have kind of a pass the mic session to see if anybody has anything outstanding from earlier today. Does anybody have a question for any of the panelists or any of the speakers that we had? You good? Otherwise, too, we could always ask questions during the reception and during the dinner as well. And then, of course, through the Rock from the Heart website, you can always go ahead and submit questions too. And also, if there are other topics you want to hear about at future symposiums as well, feel free to speak up through the Rock from the Heart website, or of course, share your ideas today, including whatever your story is. But Amy, I'll go ahead and turn this over to you.
We actually had some questions online if you want to turn them.
Sure.
I'll just walk around with the mic.
Sure. I'll give you this. Okay. Some questions came from online. First one, what complications may a two-vessel thoracic arch have in the future?
So I think the question is, so normally there's like 3 blood vessels that come off the candy cane, the thoracic aorta, and so there's the innominate, there's the left common carotid, and then there's the left subclavian, and many times people have variants of the normal anatomy, and it's people aren't symptomatic. Sometimes people can get like there's sometimes it can cause problems. So sometimes there's like a blood vessel that can go behind the esophagus and actually is one of like the unrecognized causes for chest pain. But many times just, lots of people are born a little bit different, and many times it doesn't really cause any problems.
Okay.
Sometimes it can make interventions if you're going to like end up doing stents or something up in that area. It can make it a little bit more challenging. You have to take, it may make surgeries different, but many times it doesn't cause a problem.
Okay, thanks for sharing. I have the next question here, and I apologize if I mispronounce some of these terms. Are the endographs ever made from bovine or porcine tissue?
I think they're made from like PTFE, which is like a synthetic material. And so no, they're not made from. They're not made from like cow or pig. It's usually, yeah.
Okay. The question in tandem with that one reads, does a patient need to be on long-term anticoagulation with AVAR? EVAR, excuse me.
So no. Not
You don't
long
need
term,
to?
no. Usually the blood goes, so blood clots when it's stagnant. And so, like, the more stagnant the blood, the more likely it is to clot. So the mitral valve has slower flows. So that's why, like a mitral valve would like need like a higher, like a more thin blood than an aortic valve. But because the blood is proceeding so quickly through the aortic graft, it usually doesn't. So number one, it doesn't require like warfarin or Coumadin, like the strong blood thinners. And then in terms of the antiplatelets, it's usually not like potent ones for long.
Okay, thank you. Those are the only questions that we have that came in online that I see here. Does anybody else have one from inside the room here?
I know that we had a few that came in throughout the day and that we see online. And I know we don't have the cardiothoracic surgeon here, but a lot of people hear about TAVR. And they're very young and they're afraid of blood thinners. So it comes real down that mechanical versus biological. We've talked a lot about that. And when would you decide? So if you've got a person, they're 30 years old, they're going, woohoo, we can get a TAVR, non-invasive surgery. Knowing down the road, how do you address that when you're helping somebody decide what valve they want? What's that process look like for you? How do you talk them through that and help them to make that informed decision?
The discussion is always between surgeon and the patient. Usually we are less involved in that, like as an interventional cardiologist. But typically, the rule of thumb is when they're younger than 50-year or 55-year-old, that's the cutoff right now. Because of the longevity, that's kind of like our goal. We usually the recommendation is most of the time mechanical valve. As we know that they're durable for lifetime. But the caveat is when you'll be on a mechanical valve, you need that blood thinner for the rest of your life. But once they are past that 55, 60-year age cutoff, I think the tissue valves have been shown to be equally good because you kind of like think that you probably have another 20, 30 years left in you, like if you are really in good health. And now with this TAVR procedure, we can do a valve, suppose that lasts for 10 to 15 years. So, and we have seen that the TAVR valves have been, like durable as at least 10, 12 years, and that's about the time when the TAVR started, we started doing the TAVRs. But if the valve fails, we still can go back in and put another TAVR valve inside a previous valve and make that work for another 10, 15 years or so.
Okay.
And we can do it even the third time. Okay, so TAVR inside TAVR. So far, some of the up to 3 times we can do that. So it's mostly based on the age, but there could be certain situation in really, really young folks who are in their 30s, 40s. Mechanical valve may not be a good choice during that immediate, like if they're sick for certain other things, there might be some specific reasons why the mechanical valve might not be very good. Then we can do a TAVR. And we see a lot of bicuspid patients, as we mentioned, the congenital type of aortic stenosis. They kind of like tend to show up a little early on, but sometimes these bicuspid valves are associated with other abnormalities, like congenital or some kind of like other extra cardiac abnormalities that makes their survival a little less. So if somebody has aortic stenosis we are seeing at the age of 40, but we know that this person does not have a survival beyond another 15-20 years, then in those patients TAVR makes sense even if they are young. So typically our cutoff is 20 years. You know, if somebody has a survival beyond 20 years, then we really kind of like want to give them the option of surgery with a mechanical valve, as long as their their age is under 55. But if their expected survival life expectancy is less than 20 years, then TAVR is equally attractive option in there because of the advantage of shorter hospital stay, earlier recovery.
Okay. Thank you. Anybody else? Other questions come to mind?
I got a million of these from our online group. We could go all day. This one would be regarding the diagnosis of a bicuspid aortic valve. As we kind of talked before, in my husband's case, he was told throughout his life he had a heart murmur, and it was brushed off as being innocent until a new doctor said, we should take a look at that. First visit with the cardiologist, when that was diagnosed, he said, Pete asked, should I have my son checked? Should I have my kids checked? And he said, nah, it's a birth defect. They're going to be just fine. Another question we saw this week online was somebody asked, they said that I was told that since my son is 15 and just was diagnosed with BAV, they said if he hasn't have any symptoms by now, he's probably just fine for the rest of his life. My answer, of course, was, well, everybody who had their valve replaced at 55 had a bicuspid valve at 15. So when you look at this kind of, communication confusion, when it comes to the family history side of that, should families be tested? What should they be looking for? And how do you tell, how do doctors know if a murmur innocent or not innocent?
So in terms of if a murmur is innocent or not, there are different characteristics which I basically cannot go into, but there are kind of different sounds we listen to that has to do with the way the blood gets pumped out with each cycle. And based on how that sounds, then we can get worried. For someone with a very tight aortic valve, like aortic stenosis, what we kind of hear is, you kind of hear a sound that the sound gets prolonged because it's taking time for blood to open up that tight valve. So that's kind of what we hear. And all of a sudden you hear that valve pop open and then close almost immediately because that valve is so tight. So based on all those different sounds is how we know if a valve is innocent or not. Now, if a patient sits in front of me with bicuspid aortic valve, the first thing I try to talk to them about is, all your first-degree relatives have to get screened. They need an echocardiogram, which is basically an heart ultrasound. Once you get that study done, if it shows a normal leaflet with 3 leaflets, you do not need an echocardiogram anymore. You're done. However, if it shows the bicuspid with the 2 leaflets, then you need serial follow-up with repeat echocardiogram. Usually at a young age of 15, you can start with every 3 to 5 years. However, just like we presented, once the valve starts getting leaky or tight, then the monitoring becomes more frequent. So for example, once it meets the criteria of moderately leaky or tight, then you want to get an ultrasound every 1 to 2 years roughly. And then the frequency increases, the more it gets worse, so that we can catch the patient before they get really symptomatic or before damage becomes, kind of difficult to reverse at some point. So that's what we tell most patients. So I don't agree with, no more echocardiogram after 15 years. Yes, they do need ultrasounds.
And then the final one that I kind of put in my memory banks, I tried to pull these most common questions we see, has to do with the aortic aneurysms and when do you need the surgery. So when there's no valve involvement, somebody just gets an aneurysm found, because we found during COVID with the prevalence of more CT scans, they've been finding a lot of aneurysms. So on the support pages, people are like, oh my goodness, I've got a 4.3 aortic aneurysm. What does this mean? They said I have an ascending, a descending. What does that mean? And they all ask the same question when they're first diagnosed is, can I just get a stent to fix my ascending thoracic aortic aneurysm? Since we're going to be finding a lot more of these, if I were to be, directing somebody somewhere, or what are their next steps if they're not finding someone to get them the right answers? If somebody comes in and says, I've got a 4.3 and I'm 35 years old, or I've got a 4.6 and I'm 50 years old, what does the next year look like for them, the next 2 years in the monitoring phase?
So, based on sizing, we also use kind of like the body surface area to decide the cutoff. However, for most people, the average cutoff will be 4 centimeters or less. Now, if you're 4.3 centimeters at a younger age, then I'll worry about genetic syndromes like I talked about. So I have to look for Marfan syndrome, the Lowitt-Dietz syndrome. I start looking for all that kind of syndrome so that we can follow you quickly, because then your progression is likely going to be faster than someone that is in their 50s or 60s. Usually at an elderly age, more of that aortic dilation is more from age and also lifestyle, kind of like, maybe smoking, elevated blood pressures, high cholesterol level. So with that, we just manage with medications, and at the same time, we follow them also yearly with serial ultrasounds. So just like I presented, usually if it's less than 4.5 centimeters, you can get by with just the ultrasound. However, once it reaches 4.5, then you need more of the gold standard, which is the CT scan, which will give you more of an accurate measurement and kind of guide your follow-up from then on. I hope that answers your question.
Hi. Our son was, when we had one of our first ultrasounds, we had a level 2 ultrasound when he was in utero, and they detected like an echogenic foci. And then after he was born, they detected a heart murmur for a period of time. They labeled it innocent, and it has gone away. How often do you see those types of things coming back later in life? Is that something genetically that is something that someone might want to keep an eye on and get checked later on in life? Or if the heart murmur goes away, is it truly gone away? Does that ever come back?
So I'll talk as a mother also. So my daughter also had an echogenic foci, and I had to go read about it again because I'm more of an adult doctor than a pediatric doctor. And basically, it's just one of the normal ways the heart gets developed. There's something called the moderator band on the right side, which usually starts as an echogenic foci and then basically turns into a benign muscle. The muscle does not do much on the right side, so kind of nothing to worry about. Now, in terms of other innocent murmurs, they're kind of big names for them, Graham Steele murmurs. There's so many types, but usually it goes away. And just like I said, we know innocent murmurs from murmurs that we need to worry about. If they really need to worry about, then they will follow it up. And usually if it's something that we need to worry about, it will persist and not necessarily go away. And with that, the patient needs to get frequent echoes so we can find out why they still have a murmur and we can address it.
We're a little ahead of schedule. That was all the questions we had online. I'm going to put Mike Sylvester just under the gun a little bit and ask you to go back up. Could you just do 5 minutes on the patient advocacy work that you've been doing with Essentia Health?
Has done some billboards and television commercials and things with me in them, and they have created what's called a heart health profiler, and you'll find it in your little books, and there's a QR code, and you can scan it, and it'll give you an indication of how likely you are to develop cardiovascular disease. And like I brought up earlier, I thought, well, we'll see if this works. So I went and entered in my data from when I had my heart attack and dissection in 2016, height, weight, cholesterol level, blood pressure, and it came back, you were at severe risk for cardiovascular disease. And I got an email from Essentia saying, please contact us so we can schedule a meeting with a cardiologist. And that's something hopefully everybody in this room does. Scan that code and it'll give you a good indication of how likely you are to have some type of any type of cardiovascular disease, whether it's heart valve disease, a dissection, or what I had, a non-ST elevated myocardial infarction. So there's lots of different things that can go wrong, peripheral artery disease, anything. So going to have to try to convince all my friends and coworkers to do that. So I'm really trying to be proactive, not only talk about treatments and recovery, but how we can be proactive to know our risk factors. Brought up a lot here today. Do you smoke? Do you have high blood pressure? Do you have high cholesterol? Do you maybe have a family member that's had some type of cardiovascular disease? And if you do, how important it is to go in every year and meet with your general practitioner and have them listen to your heart, to have them check your blood pressure and cholesterol. So really trying to be proactive and get out and get in forums like this to tell my story and to convince people to go in and see their general practitioner. I didn't even have one when I first had my issues because I didn't feel it was really important for me to go to the doctor, and I didn't have time. I was so busy working at the post office, and either you could make time or you're going to have time made for you when you're sitting in a hospital bed with your chest cut wide open and trying to figure out if you're ever going to live or go back to work again. So, and I've worked with the Alliance for Aging Research and done some podcasts and videos and different things and talked about stroke and epilepsy and just being proactive and managing your health and those risk factors to try to get to the point where we don't need to be having an emergency diagnosis. We can find out like Pete did ahead of time. You don't want to find out like I did, what happened, where did the last 2 months go? I've been unconscious. So it's really trying to work on getting the word out and being proactive. And Essentia has done a great job of creating marketing tools for people, and we've had direct mailings go out, I know, all over the Duluth area and even out in this area, convince people to go in and see their doctor and take care of those risk factors if they know about them. I don't know if anybody has any questions for me or at all, but
Given the fact that you had so many surgeries in such a short time period, because it was what, 6 surgeries in 6 years, I believe. How would you say this has affected just kind of your view of just life in general, like a renewed lease on life, maybe appreciating things and stuff like that?
I definitely do appreciate things a lot more and taking time to enjoy the little things. And, at first it was hard to, I didn't talk about this, but I was sitting in the Miller Dwan Rehabilitation Center kind of feeling sorry for myself. And as I was in there and there were people coming in had been in terrible accidents and crashes and had broken arms and backs and legs and head injuries, I remember thinking, you know what, maybe I don't have it so bad. I can get through this and recover. So that's part of it too, is understanding that, yes, when you have these heart valve or aortic diseases, they're going to change your life forever, but it doesn't necessarily mean that your life is going to be over. It just means that it's changed. But we definitely, my wife Amy and I, have tried to take time and enjoy things, and rather than being wrapped up in our work and everything else, which is easy to do sometimes. So yeah, we definitely have tried to spend more time enjoying our lives, because you realize that the time you have here is limited. For me, I could live to be 100. I could die in the next 5 minutes. So make sure that you take time to enjoy yourself and appreciate those little things in life.
Okay, well, we can go ahead and wrap things up then, and I'll have the reception next. So, Amy, is the reception going to start early, or are we going to wait a little bit? We'll go ahead and start. Okay. All right, so thank you everyone for attending the symposium today. This was great to hear such great information and have the different presentations, and of course the personal stories as well. And I'll look forward to just networking and connecting with all of you at the reception, and then of course the dinner after that, and then potentially the concert tomorrow night. So thanks everyone.